Ready to start the journey to pass the test?
Yes.
Okay, reminder, a set of learning tools comes with this NCLEX RN Quick Fix session. Be sure you have downloaded the learning tools. Now remember, the content of the learning tools serves as a guide. The meat of the process is in the NCLEX RN Quick Fix session. So we're gonna have sessions 4 to 6 today. If you would notice, sessions 1 to 3 has been covered in the first NCLEX Quick Fix we did a month ago. So I will actually put the link when we upload the video version of this quick fix, okay? So I'm sure everybody is ready to learn now. Okay, so welcome to session 4. Now, before I start, I'd like to ask you to join me in this mission. I have a mission. My goal is to actually provide free NCLEX RN application and review to 100 nurses. So far, I've been assisting nurses through my foundation for giving them free review. But this time, I'd like to cover also the application process because it costs so much. A lot of nurses want to turn their dreams to reality, but they don't have the means to do so, especially now that it's pandemic. So to help us achieve this, just watch and finish the ads in our videos, okay? So 1 or 2 ads that you would allow to finish when you watch our videos would definitely help us sustain our free NCLEX RN application and review scholarships for 100 nurses and more. Now, at this point in time, this is actually my giving back because teaching test preparations program for nurses has given me so much in life. And so at this point in time, I'm sharing my time and of course, my God-given knowledge to everyone such that eventually you'll best remember me, okay, when it's our time to go from this world, okay? So let's not be morbid today. Okay, so if you have some questions that we may not be able to cover the answers, please do send me an email through my email mentor.raygapos@gmail.com. That's exclusively for the quick fix question. So I will answer them personally myself. So don't worry about that. And let's begin with a message of inspiration. Some of you might be wondering what good came out of our first NCLEX quick fix session. I received a lot of feedback, but the most important feedback of them all came from Mildred from Alabama. And she says, she sent me an email last September 24 at 4:14 a.m. Hi, Mentor Ray. Thank you for your efforts of helping us. I am happy to say I passed the NCLEX 1 week before the exam. I attended your quick fix 1. Thank you and thank you again. To God be the glory, Mildred. Everybody say, I'm next. Okay. So the concepts that were covered in her test were so aligned with what were discussed. And just telling me, some of the students were telling me, well, the examples really help. So it's not just the information, but the examples that you were giving, you were integrating with the functional concepts really help. So at this point in time, I would want to receive more of this email from you guys. So after you attend this session, tell me your story. And I'm more than willing to share it to inspire others, especially at this point in time during the pandemic. And of course, we have another from our friends in Nepal. Just saw this message today. Anyway, congratulations, you did well. And she said, thank you, Sir Ray, and the entire team of Gapus. For me, one and only gold coin for entire time was the Blue Book. The Blue Book was actually a giveaway I did in Nepal. So it's this thick. It composed of all the things that you need to remember about the NCLEX. So I gave them for free there. And we are now exploring in New Delhi. Thank you. Okay, to our friends in New Delhi. Okay, this is actually Shujita and the mom. Okay. So congratulations also to Mary Flor del Rosario. And this is what she said. Thank you, Sir Gapos, for being an inspiration. Your channel and podcast help a lot too. So she actually passed her test last September 8, 2020. And she hails from Zamboanga. She studied in Ateneo de Zamboanga. And she actually did the program while she's working in Kuwait. Way to go. And somebody sent us a cake. Okay, from Elaine, USRN. Thank you so much. I don't know the surname or family name of Elaine, but we do appreciate your so sweet means of saying thank you. Okay, pwede na kahit sampalok or fishbowl. No? It's the thought that counts. Thank you very much for all of this. See what happens when we join forces together to learn? Okay, something positive comes out of it. Okay, so first and foremost, in order to succeed, we must first believe that we can. So everybody says, I believe that I can. I'm not saying that you believe me. I don't want to be messianic, you know. I'm not omnipotent, but I want you to believe in yourself. Say, I believe. Okay, because it's only when you believe that you can that you will. So always remember to say, I believe. Okay? There's a song that goes, I believe the children are our future.
I believe that I can.
I believe I can. I believe I will. I believe I must. That should be your mantra every day. Okay? Do not give up. Give it your best. And every time, always remember, the best things in life will come your way at the most appropriate time when you can best appreciate it. So everyone is saying, I believe. Okay. Okay. Okay, so let's move on.
I believe.
Yeah, I believe. You should believe in yourself, not to me. So if you can dream it, you can do it. That's according to Walt Disney. Okay? So today, somebody actually sent me an email and the student said, sir, can you give us something from yourself that will serve as our lucky charm for the NCLEX? Remember, when you take the NCLEX, there are rules. You're not, they check on your shoes. You're not supposed to be putting coin on your shoes. They check scapulars. They check whether you have handkerchief and anything like index cards, review notes, books should never be brought inside the testing room and inside the registration area. It is not allowed even in your locker. So you make sure that when you go to your testing center, you don't bring any of this because the ending would be you'll be forced to throw them into the trash bin, okay? So at this point in time, somebody asked me, sir, can you give us a lucky charm, okay? So my prize for our, remember we always have a raffle? My prize today is actually a lucky shirt, okay? From H&M. I got this in my cabinet. I bought this like 3 years ago. I wasn't able to wear it. It's polka dots, the tag's still on. Okay, so if you are the lucky winner later on, I'm gonna be sending you this shirt. You can wear this in your test. Okay, your lucky shirt. Okay, and take note, those who won last time, all of them received their prizes except for one because the address, we weren't able to locate it. It's incomplete. It's in California. So please, we'll send you an email again. You send us a Philippine address where we can send your prize, okay? Aside from the shirt, I'm also giving one of my cups, okay, as a prize. And the other one, oh, it's another cup, okay, with a G. Okay, so those of you will be lucky. Okay, send me a message now and say, I want it. Send me a message now and say, I want it. Somebody misspelled it, so wrong spelling wrong. No, that's just a trial. I will actually come up with a very, very funny question. I wish I could give you all, but you know, if I'm going to give you all a part of myself, I will run out of clothes in my cabinet because I've been giving out some of it during the pandemic, okay? So anyway, okay, we'll be giving away 3, okay? And if we can have more active participation, I'll give more. I want it, sir, said Janet. Yeah, everybody wants it too, okay? So let's move on. So something new. Now, listen to this class. Is there something new on the test? Okay. So we did our focus group discussion for our fellow learners who actually went through the process. And this is actually what came about. Most of them were saying, okay, gone are the days when you have a single sentence question. Gone are the days when you have a diagnosis in the question. Gone are the days in which the clues are so clear. When you are now given a question, the syndromic approach comes in. Now, to give more life to what I'm talking about, let me share with you an example. So here's a sample question. A 35-year-old patient is in the emergency room due to a motor vehicle accident. So you have a motor vehicle accident. Now, maybe when you see this question or this sentence in the question, the first thing that comes to your mind would be, what would be my priority for motor vehicular accident? Don't treat it that way. Always remember to treat a question as a story. Find out what the story is all about. For all you know, the motor vehicular accident is just the effect. You will have to find out and dig deep into the question, okay, to find out what's the cause of the motor vehicular accident, okay? Okay. So let's move on. So the client is conscious, cooperative, and is able to swallow. The client is manifesting irregular heart rhythm. There you go. There's an irregular heart rhythm. Tingling sensation around the mouth. There's tingling sensation around the mouth, sweating, and irritability. So you don't have a diagnosis, but you have a group of symptoms. This is what we call a syndrome. You have to understand what the syndrome is telling you. History reveals several episodes of dizziness in the past few days that led to falls and injuries. There you go. It's giving you a clue. And then bingo, bam, you find out about an objective data. Blood sugar assessment was ordered. Blood glucose is 40. But if you don't know what the normal blood glucose level is, then you are in for some difficulty. So when you have hypoglycemia, the categorical data that you need to find out is that the blood sugar of the patient is usually less than 50 milligrams per deciliter. So this qualifies as a case of hypoglycemia because the normal blood sugar level should be a range of 70 to 110. Okay, so now that you have an idea what the patient's condition is all about, then you are given a question. Okay. Which of the following interventions should be the priority of the healthcare provider? Now, this time you're being asked to prioritize. Look how the options are being formulated. Administer the calcium gluconate for tingling sensation around the lips. Now, this could be associated with hypocalcemia, okay? So is hypocalcemia the main problem based on the syndromic analysis of the question? No. Number two, administer extra fluid to replace fluid loss due to sweating. Is the sweating the main problem in the situation? Once again, no. 3, assist the patient to decrease the risk for falls. Now you would notice that for options 1, 2, and 3, they have individually addressed a manifestation on the situation. So they individually address these manifestations, but they did not actually analyze it as a syndrome. The NCLEX would want you to do it that way. Analyze the signs and symptoms in terms of a syndrome. So what is it telling you? What is the story all about? And then look at number 4, administer glucose supplements. Once again, you go back to the objective data that the blood sugar level is low. Therefore, if you want to decrease the risk for falls, if you want to decrease sweating, if you want to decrease the tingling sensation around the lips, which are all manifestations of hypoglycemia, then your priority should be to administer glucose supplements. That's what we call umbrella answer. It encompasses all the other options in the question, and that's what matters the most, okay? So let's move on. So don't give me that Gollum look. Gollum look from Lord of the Ring. Okay, so if you are faced with a syndromic type of question, don't actually sport this look. Okay, it's not very positive. Okay, so forget the Gollum look. Okay, so let's move on. So when you are faced with a syndrome in front of you when you're taking the test, what do? Okay, you use the syndromic functional concepts analysis method. So first you deal with the facts and then infer, make sense of the history, come up with a diagnosis in mind because you don't have it in the question. And then what's your plan? What's the first level plan? What's the second level plan? You have to know your priority because if the first thing that you recall as a priority doesn't come out, okay, on the options, at least you know the second level priority. And then third act, identify the intervention and the available option for you. Okay, so let's apply this into that question. So let us use the FIPA strategy. Okay, so what are the facts? There's a motor vehicle accident. You have history of falls, irregular heartbeat, tingling sensation around the mouth, and blood glucose below 40 milligrams per deciliter. So what's your inference? The patient is having hypoglycemia. So what's your plan? Your priority? The goal is to reverse hypoglycemia. Okay, and then what is your action? Immediately administer glucose supplements. Always remember to treat the facts as a syndrome. Make sense of the facts, create a story in your mind, and map it out. Okay, so let's move on. So if you go back to this question again, simply the answer is to administer glucose supplements. Okay, now based on that question, you would note that, look at this class, times have changed and so are the question. Okay, now what's an indication that times have changed? Let me share with you this anecdote. Okay, remember the story of our childhood? Okay, remember Cinderella who attended the dance in the palace, and then all of a sudden before the stroke of midnight she hurriedly left, leaving behind a shoe, and the prince actually noted the shoe. But will the prince look for Cinderella based on whether the shoe fits? What do you think? As I've been saying, times have changed. So the ending of this story has also changed. Okay. So the ending has also changed. So look, instead for looking for the princess and using the shoe, okay, to identify who owns it, so here's what the prince did. Okay. As I've been saying, class, times have changed. Okay. So they're laughing. Okay, times have changed. Yes, that's a reality. Okay, that's the new ending of the fairy tale of our childhood. Okay, so let's move on. So NCLEX quick fix, remember, test taking key. Target the cause to properly address the effect. In that previous question, the cause of all the symptoms was actually hypoglycemia. And the effects involves your tingling sensation around the mouth, your sweating, the dizziness that led to falls. Okay, so all of those things are important for you to consider, colleagues. So let's move on. So here's another question. Okay, which of the following goals of care is a priority for a client with disseminated intravascular coagulation? Okay, now take note of the main phrase, goal of care, and another keyword, the priority. So all of these could be correct and you're just being asked to prioritize. Once again, what's our NCLEX test taking tip? Deal with the cause to address the effect. Deal with the cause. Now, there are two problems in disseminated intravascular coagulation: systemic clotting, okay, and bleeding. What causes the bleeding? The systemic clotting, which would usually consume the patient's clotting factors. Therefore, which do we deal with first? Is it the bleeding or the clotting? What did we say? Deal with the cause to address the effect. What is our priority? The bleeding or the clotting? The bleeding or the clotting? Some of those who are in the chat box saying the bleeding, the bleeding, the bleeding. No, it's not. The cause of the bleeding is actually the systemic clotting, which consumed the clotting factors. So that led to the bleeding. So therefore, if you'll be asked, so what drug is usually given in DIC? They usually give blood thinners, okay, like heparin. Now, some would usually question, why are we giving blood thinner to a patient with bleeding? Because the cause of the bleeding is the systemic clotting, which used up the clotting factors. So what did we say? Deal with the cause, okay? So you can manage the effect. Okay, now, what are the related factors to DIC? DIC could be a complication of surgery. It could be also a complication associated with infection as well as surgical intervention. So you always have to remember, okay? Deal with the cause to manage the effect. Okay, so is it to prevent the development of shock? Well, that's actually a possible complication. To prevent bleeding, to prevent systemic clotting, to prevent breathing. You don't do this, of course. Okay, so you're left with options 2 and 3. What did we say? What causes the bleeding? The systemic clotting. So if this is the cause, what did we say? Deal with the cause to manage the effect. So what is our priority therefore? Is it to prevent bleeding or to prevent systemic clotting? What is the priority? It is to prevent systemic clotting. Now you know it. Excellent. Okay. So the priority goal of care in the management of disseminated intravascular coagulation is to prevent systemic clotting. Always remember that your DIC can lead to multiple organ dysfunction syndrome, and this condition is characterized by the proliferation of small blood clots. We call it microvascular thrombi in various organs of the body. Okay. So just welcoming everyone to our class. They're just coming in. Maybe the time difference has disoriented them a bit, but welcome to the NCLEX success class. Okay, okay. Okay, so let's move on. So DIC causing conditions include, we have sepsis or severe infection, trauma. We have pancreatitis, okay, the autodigestion of the pancreas or destruction of the pancreas, malignancy, and pregnancy-related conditions like abruptio placenta, eclampsia, amniotic fluid embolism, and your HELLP syndrome. Okay, HELLP is hemolysis, elevated liver enzymes, low platelet syndrome. Okay, okay. So always remember, when you are faced with a question, never give up without a fight. Okay, so one who never gives up eventually wins. Everybody say again, I believe.
I believe.
Okay, believe in yourself.
I believe.
So let's begin our journey towards passing the NCLEX. I know for a fact most of you are taking the test this month, so I'd like to share with you guys these things that I work on. So always remember, enter every activity without giving mental recognition to the possibility of defeat. Think win. Concentrate on your strengths instead of your weaknesses, on your powers instead of your problems. So leave all your problems behind. Everything will fall back into its proper place. Always remember, problems never last, but tough people do. Okay? Once again, say, I believe. Okay. Now, one of the most common challenges, one of the most common challenges that test takers would usually have is actually preparing for, amen, sir. Thank you very much. True. I believe. Believe in yourself. Okay. Claim it. That's true. Larnie, give it up. Okay. Now take note. Why are we having difficulty when it comes to prioritizing pregnant patients? Because our mindset would be, when we study establishing priorities as a concept, we focus on medical conditions, surgical conditions, that we oftentimes forget that we also need to prioritize pregnant patients. And how do we do that? How do we do that? Okay, let me share with you some secret strategies, which are no longer secret because I'm giving it to you now. Okay, this is my own way of supporting all frontliners. I know you work hard to be where you are right now, and you're doubly working hard to defeat, okay, the unseen enemy, which is the virus. Okay, so the first strategy is, take note of this class. How do you prioritize for maternal and child nursing cases? So, conditions that are considered as level 1 priorities would be any conditions that could lead to a compromise in the cardiovascular function, like a heart attack, okay? When there's acute mental status change, severe respiratory distress, seizures, signs of abruptio placenta. Now take note, class, in abruptio placenta, you have a brownish or dark red, painful vaginal bleeding. This is actually to differentiate it from placenta previa. We have bright red, painless vaginal bleeding. Placenta previa is a level 3 priority. So between abruptio placenta and placenta previa, abruptio placenta is of higher priority in the hierarchy of priorities. And then signs of uterine rupture, like for example, prolonged contraction, meaning to say the contraction is beyond 100 seconds, okay? When there's hemorrhaging, abnormal vital signs. Now, when you say abnormal vital signs, let's talk about the heart rate. When the heart rate is below 40 or when it's above 130, you consider that as a priority. Or when the BP is below 60 palpatory, or when you're taking actually the blood pressure through a machine, when the BP is below 110, okay? below 110 systolic or above 160. Or if you talk about the fetal heart rate, if the fetal heart rate is below 110 for 1 whole minute, then that could be considered as abnormal vital signs. Remember, when you're talking of MCN, you're not just talking of the mother. Even the child in utero should be considered, okay? So once again, if the oxygen saturation of the patient is below the normal, which is 95 and above, or when it's 94 and below, then that's also considered abnormal and first level priority. And take note of the last 2 conditions class, prolapse cord and imminent birth. So let me describe this. So if you see a pregnant patient with 1 or more parts of the baby now coming out of the vaginal orifice, then that's a first level priority, okay? So if it's the hand that's coming out, if it's the feet that are both coming out, or if it's the head that's coming out. So if a part of the fetus is already coming out, consider that as a first level priority, okay? Okay, so always remember what we have learned. Let's apply it. Which of the following patients should the nurse attend to first? A 32-year-old primigravida with a BP of 110/70. What did we say a while back? When you have less than 110, so this is still normal because it's 110/70. The heart rate is 105, okay? So it's not above 130. So we said it's a priority if the heart rate is below 40 and above 130. So this is still considered within normal range. So not a priority. Next, you have a 33-year-old multigravida with painless vaginal bleeding. What did I tell you a while back? Colleagues, fellow learners, when you talk about painless vaginal bleeding, that is placenta previa, level 3 priority. Our priority is a patient with a abruptio placenta, somebody with painful, brownish or dark red vaginal bleeding. So this is not the answer. Then you have a 35-year-old multigravida with fetal parts showing in the perineum. We can consider that's imminent birth. Or a 31-year-old primigravida who is sleepy but can follow verbal commands. Now, being sleepy is a normal phenomenon. But if the patient can no longer follow verbal commands, then that would mean there's decreased level of consciousness. But in this case, the patient can still follow verbal commands. So that simply means the patient is oriented. So this is not a level 1 priority. Therefore, the answer is actually number 3. Okay, that's a level 1 priority. Okay, great. We're learning fast. Okay, so what about when we are asked to prioritize psychiatric patients? Okay, now actually a lot of people are saying it's difficult to prioritize psych patients. I disagree, because there are only very, very few principles that you have to remember when you're prioritizing your psych patients. Okay, and this would actually entail remembering a functional concept. In the care of a patient with dementia, reorientation is the priority. Okay, reorientation is the priority. We're talking about a patient with dementia, because most of you would actually argue, how come safety is not a priority? In most patients, especially those with escalating anger, escalating hostility, the priority would be safety, promoting safety, verbally engage the patient, talk to the patient. But if you have a patient with dementia, this is primarily a cognitive problem. And when you have a cognitive problem, what did we say? Address the cause so you can manage the effect. Therefore, what is the cause of dementia? It's a cognitive problem. So let's address the cognitive problem. And to do that is we need to reorient the patient. Therefore, reorientation is the priority. Okay? So here's a question. Which of the following nursing care outcomes is the priority for a patient with Lewy body disease? Now here comes the challenge. You are faced with a diagnosis that you are not familiar with. We're talking about the Lewy body disease. What the hell? Okay, so Lewy body disease is actually a neurocognitive disorder. Okay, now, so that it's going to be easy for you to remember it. Let's not be too technical about it. I'm going to give you a guide. So in a patient with Lewy body disease, think about a patient with Alzheimer's plus the signs and symptoms of Parkinson's disease. So you talk about a patient, therefore, with memory impairment plus motor abnormalities, the signs and symptoms of your patient with Parkinson's disease. Now, listen up. Knowing that, having that in mind now, Okay, having that in mind, okay, let's go through the options. Which nursing care outcome is a priority? In other words, an outcome is a result of your intervention. So we are looking for an indicator that your intervention worked. That is what the question is asking you to do. Will it just be a change in behavior? Are we dealing with the main problems with Lewy body disease? Okay. Could it just be absence of injury, which could be an indication of safety of the patient? Or could it be ability to identify the nurse or a full range of motion function? It's actually the ability to identify the nurse. Why? Remember, in a client with dementia, the priority is reorientation. Now, what causes Lewy body disease is actually due to the deposition of protein known as your alpha-synuclein, okay? And this, when it accumulates in the brain, it affects thinking, memory, as well as movement. That's why the patient will have signs and symptoms of both your Parkinson's as well as Alzheimer's disease, okay? So what medications are usually given? Same as that of Alzheimer's disease, like you administer cholinesterase inhibitors. Example would be donepezil or Aricept, okay? Or Exelon, okay? Then you also give levodopa-carbidopa, medication that we give to a patient with Parkinson's disease. Now, what medication can't we not give to a patient with Lewy body disease? Which medication should we not give? Anything? Okay, the answer, antipsychotics. Why can't we give antipsychotics to patients with Lewy body disease? Because an adverse effect of antipsychotics would be pseudo-Parkinsonism. So if you're going to give, okay, your antipsychotics, you worsen the patient's condition. You worsen the patient's condition. Excellent. Everybody is actually getting the correct answer. Thank you very much for chatting. Okay. So always remember, address the cause so you can manage the effect. You don't have to memorize facts about Lewy body disease. Just have a clear idea. It's a combination of the symptoms of Alzheimer's plus Parkinson's disease. Okay? Okay. Okay, so let's move on. So how do we've taken up prioritizing pregnant patients, prioritizing psych patients. Now, how do we prioritize this time pediatric patients? Okay, now always remember, very young patients, especially those who are below 1 year old, should always be given, okay, second look. Because chances are, if they're manifesting a condition that necessitates emergency intervention, then those children could actually be considered as a priority. So therefore, let's turn that into a test-taking strategy. Can we therefore say that we can identify the pediatric patient who should be our priority based on the age of the patient alone? Yes, you can use the age as your starting point. So if you have several options that deals with somebody below 1 year old, analyze each option carefully, okay? Okay, that's a strategy. Let's move on. So remember this functional concept, pediatric patients with iron deficiency anemia must be assessed for their diet. So if you'll be asked, what is the priority for a child with iron deficiency anemia? Well, check on their diet. Why? Let me tell you about this. The iron reserves of a child from the mom usually would last only 3 months. So the child, the infant, would have adequate iron reserves for 3 months after birth. However, take note, colleagues, after 3 months, you will have to give them iron-rich supplements that should begin at 4 months. Okay, you could give them cereals. It's hypoallergenic, high in iron. Or, take note of this, your egg yolk. Egg yolk should be given first. You don't give the egg white until the child is 1 year old because the egg white contains albumin, a form of protein that could potentially trigger allergic reaction. Okay? So how will a child with iron deficiency anemia look like? Well, they would be chubby, but they would be pale. And the common cause of iron deficiency anemia is that they're not given iron supplements at the appropriate time such that, okay, the parents would usually serve milk, 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 and milk. So excessive milk intake, therefore, is a risk factor for iron deficiency anemia in whatever form, whether it's cow's milk, goat's milk, even breast milk is low in iron. Therefore, the question now is, how excessive is excessive? Okay, actually, milk, whether it's cow's milk or goat's milk or whatever milk, okay, is encouraged once a child has already reached 1 year of age, such that, okay, the American Academy of Pediatrics recommend that within that time, okay, the milk intake should not be more than 4 cups a day. So how many ml would be 1 cup? Approximately 240, because it's 236 point something. So 240 ml. So 4 cups of milk would mean around 1,000 ml or 1 liter of milk per day. That's allowed. But beyond that, say for example, if a child is taking 1.5 liters of milk per day, that's excessive milk intake. So in essence, okay, in essence, that increases the risk for iron deficiency anemia. Okay, so let's move on and let's figure things out. So here's a question. Which of the following questions is appropriate to ask the mother of an 18-month-old child? Okay, remember, after 1 year old or 12 months, the maximum milk intake should be 4 cups per day. So you have here a child who is chubby but pale. Again, this is very syndromic. You don't have iron deficiency anemia in the question, but this syndrome is telling you that the child is having iron deficiency anemia. Is it 1? From whom do you think your child inherited his skin tone? Is that appropriate to ask about an inherited skin tone? I remember one nurse, he was trying to measure the height of a patient. And then the patient actually is short, okay? So the nurse asked the patient, oh, you stand 4 feet 6 inches, okay? From whom do you think did you get your height, okay? And then it was actually, what is in the mind of the nurse is she was actually trying to assess whether it's the mom or it's the father who is short. But lo and behold, the patient answered with a mind-boggling answer. What was it? He said, I'm short because I don't have parents. I'm an orphan. And then the nurse actually said, so what does that have anything to do with your height? You see, the patient said, I'm an orphan, so nobody raised me. Nobody raised, that's actually a very literal understanding of the word raise. Okay, let's go back to the question. Number 2, is your child fond of eating egg whites? Now, this is not indicated for children, okay, until they're 1 year old because it could actually cause allergy. Can you tell me how much milk does your child drink? Excellent. How did you manage to keep your child chubby? Okay, so the most appropriate response is actually number 3. Can you tell me how much milk does your child drink? So everyone is actually learning fast. Way to go. Okay, so let's talk about care of the infant, okay, in terms of the things that we need to assess the infant for, okay? Pay particular attention to this. Iron supplement should begin at 4 to 6 months. You begin with cereals or egg yolk. And then no choking hazards. Common choking hazards for them would be hot dog, grapes, okay? So no choking hazards, don't feed them with hot dogs. Okay? Fear of stranger peaks at 8 months. Okay, the previously friendly baby now is able to identify the primary caregiver. So that's why they have what we call stranger anxiety. Okay, that usually peaks at 8 months. And this is actually a normal behavior. Allow the use of pacifier if the patient is an NPO. Remember that the child is usually in the oral stage of development. So you have to meet their oral needs. Now note the weight, take note, the weight doubles at 6 months, but if you have an option that says the weight doubles at 5 months, then you could actually answer 5 months. It triples at 1 year and it quadruples at 2.5 years. Don't forget the developmental task, trust versus mistrust. That's according to the theory of Erickson. And finally, what type of play will they have? Solitary play. So what type of toys do you give them? Toys that stimulates the senses. That's a general functional concept. So colorful toys, toys that make sounds, the duck that squeaks, okay? So all of these are appropriate for infants. So let's move on. Now, if you're going to ask me, so what is it that we need to remember about care of the infants? Take note of this, class. remember about the MoroReflex or the startle reflex, okay? Why? Because it's the most sensitive index of the integrity of the central nervous system of the baby. And take note, the MoroReflex is typically suppressed at 3 to 4 months. So is it a red flag if the MoroReflex becomes exaggerated? Yes. If the MoroReflex is still present beyond 4 months, say for example, the child's already 5 months or 6 months, then that's a red flag. You may want to consider having the child assessed by a medical practitioner for a potential for TaySachsDisease. We'll talk about that in a while, okay? So the MoroReflex is elicited by loud noise, okay? A blow or jarring to a supporting surface when you move the supporting surface, or sensation of being dropped 5 to 10 centimeters through space, okay? So this is the normal reaction when you have the MoroReflex. Now remember, within the first 3 to 4 months of age, the child cannot change position. They cannot roll over. So the MoroReflex serves as a protective reflex. It's a warding of reflex. They have continuous abduction and adduction of both the upper extremities. Now, what if there's only one upper extremity that's moving? Well, you could actually have the baby assessed for possible brachial nerve injury. That could be related to the type of birthing, okay, or delivery of the mother. Okay, so let's move on. We also have another reflex. It's called the parachute reflex. It's elicited by suspending the infant on prone position. Once again, this is a protective reflex. And take note, this manifests after the MoroReflex has disappeared. So if the MoroReflex has disappeared at 3 to 4 months, at 4 to 6 months, okay, the child will exhibit now your parachute reflex, okay, in which the arms and hands and fingers will be extended as if flying, okay. Now, what happens when beginning at 4 to 6 months, the child will not manifest your MoroReflex? So it simply means that the child could be having cerebral palsy, okay, cerebral palsy, okay. So pay particular attention now to these reflexes, okay? So this is your parachute reflex. You have the forward parachute reflex here at the bottom. You also have the backward parachute reflex. Note that the fingers as well as the arms are extended, okay? You also have the sideward parachute reflex. Once again, the fingers are extended, okay? As well as the arms. You also have a downward parachute reflex. When the child is falling, look, the arms are again extended and including the fingers, okay? So what is important at this point in time is that you know for a fact that the presence of the MoroReflex in the first 3 to 4 months and the presence of the parachute reflex from 4 months thereafter are considered normal. Okay, so the MoroReflex disappears at 3 to 4 months, while the parachute reflex appears at 4 to 6 months. Okay, so let's move on. So an exaggerated MoroReflex or startle reaction to loud noises may indicate your TaySachsDisease. Now pay particular attention to the fact that your TaySachsDisease could actually be common among your Jewish babies. Okay, now, what are the things that you have to pay particular attention to? Okay, in patients with TaySachsDisease, they will have the cherry appearance, okay, in their eyes, okay, cherry red appearance, okay? The most common form becomes apparent within the first 3 to 6 months of life. That is why a common indicator of TaySachsDisease would be an exaggerated MoroReflex, because okay, the MoroReflex should have disappeared at 3 to 4 months. But in patients with TaySachsDisease, they continue to exhibit it, okay? So infants with TaySachsDisease lose the ability to turn, sit, and crawl. Once again, they lose the ability to turn, sit, and crawl. Now, I'd like to focus your attention to these 3 motor activities, okay? Question. At what age do you expect the child to begin to turn? Now, always remember this. That's related to the MoroReflex. You don't expect the child to turn in the first 3 months because they have the MoroReflex as a protective reflex. So they begin to turn from their belly to the back, okay, at approximately 4 to 5 months. Once again, belly, if they are lying on the belly, they turn to the back at 4 to 5 months. And then they can also turn from the back to the side along the same time, 4 to 5 months. But when do you expect them to turn from their back to their belly? It's at 5 to 7 months. Okay, once again, turn from back to belly, 5 to 7 months. Turn from belly to back, okay, 4 to 5 months. At what age will you expect the child to sit? It depends, okay? The child will sit without support at 8 months. The child will sit with slight support at 6 to 7 months, okay? Now, what about if you have an option that says sits without support at 7 to 8 months? You can actually choose that, okay? Now, when do you expect the child to crawl? Okay, what comes to your mind when you see the word crawling? Okay, somebody just told me, my husband, sir. At what time will the husband crawl out of bed? Okay, now pay particular attention to this class. How do we differentiate crawling from creeping? When you say crawling, it's like, you know, when soldiers go to war, okay, they lie on the floor with their belly in contact with the floor. That's crawling. The baby's belly is still in contact with the floor. And this is expected at approximately 7 months. So the child crawls at 7 months. Now, how is crawling different from creeping? Okay, creeping is actually also a motor skill that's developed at approximately 9 months. And this time, the child already moves on the hands and the knees. The belly is no longer in contact with the floor. So once again, so which is more primitive? Crawling. Which is more advanced? Creeping. So always remember, the child, how will the child actually manifest normal motor development? They first turn, then they sit, then they crawl and creep. So if you will have an item on the test that says arrange in order in terms of progression, then you begin with turn, sit, crawl, and creep. But what if, remember our what if mentality that we learned on our first quick fix session. What if you have an option that says turn from belly to back and then turn from back to belly? So which should come first? Always remember, turning from belly to back is usually attained at 4 to 5 months, and turning from back to belly is at 5 to 7 months. So how do we arrange it? Okay, turning from belly to back, then turning from back to belly, sit, crawl, and creep. Excellent. Okay, so remember that and don't ever forget that again. Okay, now notice that when your baby has very poor muscle control, and when you pull them up, the head lags behind, okay? So this is not parachute reflex. You don't label this as parachute reflex, because in parachute reflex, the baby would actually usually, okay, extend the arms and the fingers. They're not happening here. So this is actually muscle weakness associated with TaySachsDisease, okay? Now, always remember to identify what could be an NCLEX issue. So always remember, identify what could be an NCLEX issue, okay? So when you say NCLEX issue, you have to know, okay, what are the things that you need to be prepared for in relation to the concept. I'm just welcoming some of our friends, okay. Okay, thank you. Okay, so let's begin with the functional concept. Now, what are the significant data that we need to pay particular attention to when you have an infant as a patient? Okay, sometimes this could actually raise red flags. First, when you have a baby who's overly behaved, when a mother says, God has gifted me with a well-behaved baby, he seldom cries. Well, that's not a positive indicator, because usually babies communicate by crying. So when you have an overly behaved baby, note that the child could be having cretinism, which is a form of hypothyroidism, which could be congenital and could lead to mental retardation if not properly addressed. So this would mean that you have to refer the mother to an endocrinologist, okay? My cousin from Germany is watching, is joining, okay. Hi, hello. Okay. Okay, next. Restlessness may be indicative of hypoxia. So do you consider a baby with restlessness as a first level priority? Of course. Hypoxia could actually be a danger sign. Asymmetry of facial features. Like if you have a baby in which one eye is smaller, then thin upper lips, okay? Receding chin, okay? And then short nasal bridge, okay? Then suspect fetal alcohol syndrome. So ask the mother, did you drink alcohol while pregnant? Okay, those are the things that you have to consider asking the mother. And last, large tongue. Oh, is this a welcome thing? Some people would want someone with a large tongue. Well, babies with large tongue usually have trisomy 21 or Down syndrome. Now, what's the implication of babies with large tongue? This will make it difficult for them to suck on milk. So the priority nursing diagnosis would be altered nutrition because of their inability to suck properly, okay? Although for some, having a large tongue could be an asset, okay? But for the baby with Down syndrome, it's not, okay? So let's move on. Now, what if what is being asked would be about preterm babies? Say, for example, characteristics of preterm babies, okay? So let's pay particular attention now. How would you actually classify the baby as preterm? Well, if they are born less than the expected number of weeks before delivery, okay? 37 to 40, some would say 37 to 41 weeks, okay? Now, but most of those experts would usually say that a child that is born with a weight of less than 2,500 grams or 5 pounds, 8 ounces, okay, is classified as preterm. And what is the danger? Well, they have lesser fats that would insulate them from temperature changes, okay? And that's a danger because the child could actually die of cold stress, okay? And then their skin is thin, shiny, and pink, and sometimes you would notice the blood vessels from their skin, okay? And of course, they have little scalp hair, but a lot of lanugo, the fine downy hair that you would notice usually, okay, on the shoulder and on the nape area, okay? Okay, admitting your friends again, okay? And then of course they have weak cry and underdeveloped genitals, okay? So, I remember somebody, okay? She asked her suitor, are you a preterm? So what is the implication if somebody asks you if you're a preterm? Okay, think about that. Okay, so anyway, we have some friends again coming in. Sorry for the interruption, guys. We'd like to help as many nurses as we can. Okay. 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 Okay, so what are the things that we need to remember for preterm babies? They are usually at risk for pneumonia, okay, because of immature lungs, okay? Sometimes they have sudden infant death syndrome, okay? So you never actually leave them on their belly. You always leave them on their back, okay? To prevent sudden infant death syndrome. Resistance to infection is low because of their immaturity. Then they experience elimination problems. Okay, their temperature regulation is unstable. Once again, this could be due to immature central nervous system as well as the limited amount of body fats. And what could be a cause of preterm birth? It could be related to maturing placenta or placental factors or uterine factors, like for example, unexpected premature rupture of membranes, okay? And then R, respiratory difficulty. And then finally, the more common causes of mortality, septicemia, sorry, I'm admitting your friends, diarrhea, and of course, meningitis. Okay, now, what are the anticipated things that you have to be familiar with in preterm babies? The temperature regulation is immature, resistance to infection is low, they have itchy liver, so sometimes they have jaundice. But how do we differentiate whether that's physiologic or that's pathologic jaundice, okay? If they are born with yellow skin, so chances are that is pathologic jaundice because it means that in utero, they are already having RBC destruction. Okay, so if that happens several hours after delivery, okay, usually beginning on the 2nd day up to the 10th day, then that could be physiologic jaundice. But if the jaundice persists beyond 10 to 14 days, then you have to rule out for biliary atresia. And then elimination problems, specifically pay particular attention if the baby is gonna have meconium ileus. Now, meconium ileus is usually due to the blockage, okay, of the GI tract. And this also comes with a blockage of the respiratory tract. If this happens, what condition should we suspect the child to be having? We suspect cystic fibrosis. Now, cystic fibrosis is genetically transmitted by autosomal recessive pattern, which simply means that both parents should have the trait for their children to have 25% chance of having the disease. How will you know that the baby has cystic fibrosis? When you begin to kiss the baby, and then the baby tastes salty. So if the baby tastes salty, that simply means that the skin is impermeable to sodium. All the sodium components, okay, that circulating the child's body is coming out of the skin and it's not being reabsorbed back, okay? That would tell you, that's a red flag, that the child is salty when kissed. So that's an indication that the child could be having cystic fibrosis. Okay, so what's a complication of cystic fibrosis? Aside from the frequent respiratory tract infection and the blockage of the respiratory tract due to thick mucus secretions and the blockage of the GI tract, okay? For male babies, this could actually lead to sterility, okay? And usually, children with this are given digestive enzymes as a form of treatment, and they are given exercises to promote patency of the airway. Like they will be asked to blow bubbles or blow trumpets, okay? Just to facilitate the elimination of excess mucus, okay? And to facilitate breathing, okay? Now, to whom would you refer the parents of children with cystic fibrosis? Well, we refer them to geneticists as well as to nutritionists. Why do we need to refer them to geneticists? So that they would be able to understand how their kid got it, okay? So it's nobody's fault. It's not their fault. It's in their genes. You cannot actually change what's being designed by nature, but you can at least modify the symptoms. So you need to also refer them to a registered dietitian. So the diet would be high calorie, high sodium. Why high sodium? Because you will need to replenish the sodium that they're losing on their skin, okay? And of course, you have to assess for their sensory perceptual function, okay? Now, what about if we're talking about post-term babies? Okay, post-term babies, okay, if we're going to differentiate them from preterm, okay, for preterms you have thin, pinkish skin. For the post-term, you have post-mature skin, okay? They're a little thick, and then they usually have oxygen hunger. Then you will have signs of placental aging, like difficulty in breathing. The fingernails are thick. Well, that is expected in a post-term baby. But is that a thing that you have to focus on? You may have to document it and observe it properly, okay? But if you have a post-term baby, to a certain extent, that is expected. Worry if the fingernails come with colors, okay? They have nail polish on their fingernails. That's something that you should be worried about, okay? That's just a joke, okay? Now, you also would notice that their toenails are long and the extremities are long. And then this time to differentiate it from a preterm baby, you have reduced lanugo and absence of vernix caseosa, okay? Okay, the whitish cheese-like substance, okay, that you find in the baby. Okay, so excess lanugo, you have preterm. Reduced lanugo, you have post-term. Excess vernix, you have preterm. Absence of vernix, you have post-term. And then assess for potential meconium aspiration, which could actually lead to fetal distress. Okay, excellent. Now, Whatever things we learn is useless if we don't use it. Let's do this together, colleagues. Okay, which of the following characteristics are found in preterm infants? Okay, we're talking about preterm. Okay, reduced lanugo? No. Reduced lanugo is in postterm. Excessive lanugo is in preterm. Lots of lanugo, yes. Now look at this class. You have two options that are opposite. Always remember, okay, one of these is incorrect and one is correct. So therefore, when you have options like this, be clever enough to just put a check on one. But that's what is difficult, just like in life. When you have two suitors left, you wouldn't know whom to give your yes answer to, right? Okay, so weak cry, yes. And then absence of vernix caseosa, once again, this is for the postterm. We're talking of the preterm. And shiny pink skin, yes, that's characteristic of the preterm. So remember, everything starts in your head. So stop making excuses. Just do it. So everybody, once again, say to yourself, I believe. Congratulations to Trixie Del Rosario from Iloilo Doctors College. She's actually residing in New Jersey, and she actually joined our online review class, and she actually passed the Hawaii State Board of Nursing last September 21. Way to go, Trixie from New Jersey. I'm so glad that I was able to help you turn your great American dreams to reality. And I hope that with all of you guys here listening, we can also do the same for you. That's my mission, okay? Let's move on. Now, okay, let's talk about AKI. So this is your acute kidney injury. To those who were born in my generation, this is called, so sorry, our age would actually tell us how diseases are labeled during our time. During our time, this is called acute renal failure. Okay, times have changed, as I've been telling you a while back. So it's now called acute kidney injury, so AKI. So what do I want to tell you? So if you see AKI, to those who belong to my generation, think about acute kidney injury. Clear? Okay, so AKI, think about acute kidney failure. Okay, now for us to be able to analyze what happens in AKI, it's very important that we know the basic functions of the kidney. You have to recall all the functions. You have to know the basic ones. So we all know that the kidneys are the ones that filters our blood, and part of it would actually become, okay. Okay, somebody said, congratulations, I believe. Okay, thank you, thank you. Okay, 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 congratulations to our pastor. Okay, so once again, we all know that our kidneys filter our blood, okay, and turn some of it into our urine, which could be an indicator of the fluid balance in our body. Remember, we have to have 30 to 60 ml of urine output per hour. Now, since the kidneys filters our blood, it's also responsible for excreting waste products, specifically urea from protein and uric acid from nucleic acids in the brain, okay? So in essence, since the kidneys are excretory organs, they help maintain the balance of electrolytes by reabsorption of nutrients like sodium, water, amino acids. And they also maintain osmolality. What do you mean by osmolality? Osmolality means the concentration, okay, of water and electrolytes in the blood or in the urine, okay? So in essence, since it regulates your electrolytes and your water, your kidney has a role in maintaining blood pressure. So in a nutshell, all of those function, let's turn them into one functional concept. The kidneys, okay, excrete waste products, okay, and balances electrolytes and fluids in the body. And that's usually manifested in your blood pressure and the urine output, period. Okay, so let's move on. Okay. Okay. So here's a question. An elderly client is brought to the emergency department for inability to void and abdominal enlargement. Initial impression indicates acute kidney injury. So click on the exhibit. Oh, sorry. Okay, so here's the exhibit. Okay, which data in the patient's history is related to acute kidney injury? History of chickenpox as a child. Now remember, the condition is acute. This is history as a child that has long been there. I'm not saying that exposure to bacterial or viral infection may not be related to kidney injury, but hey, we're talking about acute kidney injury, which could mean it could have happened within 24 hours to 7 days. Okay, so treatment with neomycin, we can consider that. Exposure to common colds virus in the previous year. Once again, this is already history. Diagnosed with hypertension. Okay, you're left with these two options. Okay, now, if the diagnosis of hypertension occurred, okay, as a child, so this could be chronic hypertension, so which could potentially have injured the kidney acutely. Now remember, we have drugs like your aminoglycosides, okay, streptomycin, neomycin. These are ototoxic, so it damages cranial nerve 8, neurotoxic, it could potentially cause seizure, and nephrotoxic. So if the patient has taken this medication would experience oliguria that progresses to anuria, then suspect acute kidney injury. So the answer, therefore, this is related to the treatment with the antibiotic. Okay. So acute kidney injury refers to a sudden, okay, it occurs within 7 days, episodes of sustained more than 24 hours decrease in kidney function. It could also affect the brain, the heart, and the lungs. Now, there are 3 classification or cluster of causes of AKI. So you have pre-renal, intrarenal, and post-renal causes. Now, let me explain this in a bit. When you say pre-renal, any condition that leads to decreased blood flow. Example, hypotension, shock, decreased heart function, overuse of non-steroidal anti-inflammatory drugs, okay? Take note, how can NSAIDs lead to decreased blood flow? Because your NSAIDs has a vasodilatory effect. So if it dilates the blood vessels, eventually the flow of blood will meet less resistance, okay? Okay, so potentially causing decreased blood flow. Severe allergic reactions, burns, injury, and major surgery. So take note, patient with burns is at risk for AKI. Okay, direct kidney damage, like conditions that directly affects the kidneys like sepsis, multiple myeloma, okay, vasculitis, interstitial nephrosis. Now, what happens in multiple myeloma? This is actually a form of cancer, okay, that may potentially affect the kidneys. Now, what happens in interstitial nephritis? There's an inflammatory reaction that occurs within the kidney, okay? And scleroderma is a form of autoimmune disease that leads to tightening of connective tissues that could potentially also affect the blood vessels or the connective tissues in the kidney. And of course, in glomerulonephritis, you have inflammatory reaction in the glomerulus or glomeruli, okay? Your post-renal causes of AKI includes any condition that blocks the urinary tract. Now, what are these? So any condition that blocks the urinary tract, you have post-renal causes. You have bladder or prostate, cervical cancer, BPH, CNS condition that affects urination and bladder function like multiple sclerosis, kidney stones, and of course, blood clots in the UTI. So let's simplify this. Any condition that decreases the flow of blood like shock, okay, burns, is considered the pre-renal factors. Any condition that directly damages the kidneys are considered, the conditions are considered your intrarenal factors. And any condition that tends to block the urinary tract, these are considered, these are known as your post-renal factors. So BPH, post-renal, glomerulonephritis, intrarenal, burns, pre-renal, shock, pre-renal, okay, sepsis, intrarenal. Okay, excellent. Okay, so let's move on. So what are the different tests for AKI? Well, you begin with the most basic ones. Don't ever forget the basics. So we begin with urinalysis, and then your non-invasive tests like ultrasound, okay? And then your kidney biopsy, okay? You could actually do your kidney biopsy, and then you monitor the patient's ability to excrete, waste products, BUN, okay? The normal is usually 10 to 20. Creatinine, normal is 0.5 to 1.5. Phosphorus and potassium levels, okay? So your normal phosphorus would usually be 3 to 4.5 milligrams per deciliter. Potassium would be 3.5 to 5.3, okay? Now, one thing that you also have to pay particular attention to would be the glomerular filtration rate, okay? So if the GFR is below 15, that's an indication of renal failure and dialysis would be needed. So what's a normal GFR? It's usually 90 and above, okay? So when the GFR begins to fall to 60, it simply means that the kidney is not functioning properly. And if it falls to 15 and below, then the patient may need to have dialysis. Okay. So the diagnosis of kidney impairment is based on, take note of this, the rifle criteria. RIS, which means there's increased creatinine and decreased urine output for 6 hours. Injury, which means there's increased creatinine, usually double the normal level, and decreased urine output for 12 hours. Failure, okay, which means there's increased creatinine times 3 and anuria for 24 hours. Then loss, then you have increased creatinine times 3 plus anuria for 24 hours. And finally, end-stage kidney disease. So take note. This is the progression of your acute kidney disease. You begin with a risk when you have decreased urine output for 6 hours. Then it's called injury when the urine output is decreased for 12 hours. Then you have failure when you have anuria for 24 hours, or loss of kidney function when you have anuria again for 24 hours, and end-stage kidney disease, which would tell you that the kidneys are already not functioning, okay? Which means the GFR could already be less than 15. What would tell you that the patient's condition has already progressed to end-stage kidney disease? When the patient with anuria eventually manifests GI condition, symptoms like nausea, vomiting. Why is that so? Because take note, the kidneys are located behind the peritoneal cavity, retroperitoneally. So if the kidneys are no longer working, all the waste products are accumulated there. So it diffuses into the GIT, triggering now the vomiting center. So in end-stage renal disease, the patient will have nausea and vomiting. So if a patient with kidney impairment manifests nausea and vomiting, all of a sudden, is that a reportable manifestation? Yes, it is. Because it is indicative that the patient's condition has worsened to end-stage kidney disease. Okay, we're learning. Great. Now, take note, the priority goal of care in AKI is to eliminate causes of reverse kidney failure. Now, how do we eliminate the causes? Remember this, the question? What could potentially cause acute kidney injury? Treatment with nephrotoxic drugs. Okay, so you have to eliminate your nephrotoxic antibiotics. So what's a test-taking key? Map the story in your mind. Create a movie in your mind related to what you're reading. Never treat a question on the NCLEX as a question because it becomes threatening. Treat it as a story. Treat it as a story, okay? Now, I'd like to highlight at this point one procedure related to your kidney injury. It's going to be urine collection for creatinine clearance. We all know for a fact that the most sensitive index of your kidney function would be your creatinine. Okay. Will it be the serum creatinine or the creatinine clearance? The creatinine clearance. Okay. The creatinine clearance. Okay. Okay. I'll answer your question after our first session. Okay. In a nutshell, the difference between failure and loss, they're almost related. Okay. The two. Okay. Loss usually occurs when the GFR falls below 15, okay? In failure, the GFR could still be above 15, okay? Let me just welcome our friends again. Okay, thank you. Okay, let's move on. Oh, there's one again. Okay. So a creatinine clearance test requires the measurement of creatinine levels in a 24-hour urine collection. So what do we need here? 24-hour urine collection. So the normal range of creatinine clearance would be 77 to 160 ml per minute per body surface areas. Now, are there any food restriction before the collection? Yes, we need to instruct the client to avoid some fruits like avocados, banana, okay, including some vegetables, okay, like butternuts, cantaloupe, dates, eggplant, grapefruit, kiwi, melon nuts, pineapple, plums, and tomatoes. Why is that so? They have the potential to alter the results of the test. And we also ask the patient to avoid cough syrup that contains guaifenesin, L-dopa, acetaminophen, and salicylates. Once again, why they alter the results of the test. Okay, now this is where I'd like you to focus on, okay? How do you gather the specimen? What instruction will you give the patient? Remember, okay? Remember to do this. First, okay, we instruct the patient that a 24-hour urine collection has a beginning and an end time, okay? So we map out a plan. When will the patient begin to collect, okay? And when will the patient end the collection? So always remember, the first urine of the patient for the day is not included because that has been formed in the past 24 hours. So in a 24-hour urine collection, what we're going to collect would be the urine output from the start time to the next 24 hours, such that, what do we tell the patient? Urinate in the toilet upon getting up in the morning. So the first urine is not included. Then collect all urine for the next 24 hours. On the next day, urinate in the container upon getting up in the morning. So in other words, the first voiding is not included, but the last voiding on the second day would be included. What does that mean? Okay, so in Tagalog, to our Filipino friends, okay, yung unang ihi, hindi kasama. Pero sa susunod na araw, yung unang ihi, kasama. Okay? Okay. So on the next day, urinate in the container upon getting up in the morning. Cover the container and keep it in a cool place with an ice, okay, or a fridge. Label it with the name, date, and time of completion, and send it immediately to the laboratory, okay? So to gather a 24-hour urine specimen from an infant, what if you are being presented with a patient who is an infant? Use a urine collection bag, okay? If you have males, place the penis in the bag and then attach the adhesive on the abdomen. If you have females, place the bag over the labia. And is it still all right to use diaper over the urine bag? Yes, you can still use the diaper over the urine bag. Okay, so let's try answering sample questions. Okay, here we go. The nurse is giving instructions to a client for 24-hour urine collection for creatinine clearance test. Please arrange the following steps in order. So what do we need to instruct the patient first? Okay, so we begin with instructing the patient to use the plastic cup for each urine collected. Okay, okay, and then pour the urine onto the collection container. Okay, and the third step, okay, don't forget the third step, keep the urine refrigerated and, okay, sorry, urinate at the end time and keep the urine refrigerated. Sorry for that, okay, technical problem, okay. So it should be BC, okay, DA, sorry, BCAD, sorry for that. So urinate at the end time and keep the urine refrigerated, okay? Please take note, use the plastic cup for each urine, pour the urine to the collection container, urinate at the end time, and keep the urine refrigerated. Sorry for the mix-up. Okay, now let's move on. Let's talk about, this time we talk, early on we talk about acute kidney injury. This time let's talk about ARDS, okay? This is acute respiratory distress syndrome, okay? So this is also referred to as acute lung injury. Okay, so what are the things that you should remember when you see ARDS or acute lung injury? Think about respiratory distress. Think about respiratory distress. Oh, somebody asked actually from the question. Thank you for this question. Okay, before we move on, the question is, how much fluid is usually given to a patient with acute kidney injury? Okay. Okay, before we move on to ARDS. Well, the amount of fluid replacement should be based on the output of the patient. So the general formula would be fluid losses plus 500 ml per day. So in case a patient has a total amount of urine output of 300, so your fluid replacement should be 300 plus 500 ml. Now, in case the patient had no output at all, so you have anuria. So what happens? Okay, so if you have anuria, okay, you just administer 500 ml per day. Okay, so the preferred solution would be definitely your saline, 0.9% saline solution, your crystalloid solution. Okay, now pay particular attention that, thank you very much for that question, that fluid administration is one of the most common hospital intervention that is implemented, okay? Not just for acute kidney injury, okay? So thank you for the question. Going back now to acute lung injury, okay? So let's proceed. Now remember, ARDS occurs when the alveoli gets filled with fluids and it develops within a few hours. So what happens now? Okay. What happens now when you have acute lung injury? Think about a patient having respiratory distress. So think about a patient having respiratory distress, okay? So ARDS could be due to coronavirus disease. This is common nowadays. Head, chest, or other major injuries. Other factors like pancreatitis. Now my question is, here's a question. How can pancreatitis lead to ARDS or acute lung injury? Take note that in pancreatitis, you have autodigestion of the pancreas, self-destruction of the pancreas that's mediated by an autoimmune reaction, okay? Okay, in which case there's an increased level of serum amylase and periumbilical pain. Question, how will that lead to acute lung injury? In pancreatitis, okay, the autoimmune reaction leads to inflammatory conditions, and the inflammatory condition extends to the lungs. So when the lungs becomes inflamed, then that results to your acute lung injury. Now remember, in acute lung injury, fluids would usually also accumulate in the lungs, and that could be associated with near drowning or aspiration, as well as in pneumonia and sepsis. The most common among all these factors, remember the code CHOPS, would be sepsis. Okay, so let's move on. So chronic alcoholism increases the risk for ARDS. And patients with ARDS are placed on ventilators. I know what you're thinking, guys. You're usually having like, oh my God. One of my friends told me that I have to study about ventilators. Now you begin to think like a respiratory therapist, but no, don't look at it that way. The test is for nurses, okay? So it's a test to actually give you a license to practice professionally. So when you're studying ventilators, focus on the things that a nurse should know. So like what? Like this one. Patients with ARDS are placed on airway pressure release ventilation. So why are they placed on APRV or airway pressure release ventilation? Okay, take note that your airway pressure release ventilation makes the expiratory phase longer than the inspiratory phase. So what happens when this occurs? Therefore, your airway pressure release ventilator prevents atelectasis or the collapse of the alveoli. Okay, so the first thing that you have to know is what is the purpose of your APRV in a client with acute lung injury? And your answer would be to prevent atelectasis. Got it? 1 point. Okay. Next important thing about ventilators. Okay. Always remember what I've been telling you a while back. Remember the basics. Do not forget the basics. So let's go over some definitions. FiO2 means fraction of inspired oxygen. So in layman's, this is how much oxygen the patient is receiving. What is the normal FiO2? Now remember, your code should be, your FiO2 should be a little higher than the atmospheric level of oxygen. We all know for a fact that in the atmosphere, like there's 21% of oxygen. So in FiO2, that should be higher, okay? So it should be 0.5 or 50%, okay? Not beyond 50%, because that could lead to oxygen toxicity. Now, how will you know that the patient is having oxygen toxicity? The patient's having oxygen toxicity if the patient begins to exhibit central nervous system manifestation. Example of CNS manifestation of oxygen toxicity, the patient may have headache, okay? The patient may have dizziness, the patient may have decreasing level of consciousness, okay? And these are all very, very important for the nurse to note. Okay, so eventually, will a patient with oxygen toxicity have muscle twitching or blindness? Yes, they could even have confusion. Now, sometimes they have what we call cogwheels breathing. What is cogwheels breathing? Interrupted breathing, okay? Interrupted breathing. If you increase the level of FiO2, what is the danger if it goes beyond 50? The danger would be retinopathy, damage to the eyes, okay? Then we have PEEP, positive end expiratory pressure. This refers to the amount of pressure at the alveoli at the end of expiration. So which means PEEP facilitates gas exchange. Now it's expressed in terms of normal value, in terms of centimeter of water. So it's 5 to 10, okay? Then you have the rate, refers to respiratory rate as determined, okay, by the physician based on the patient's status. Normal, 12 to 18 per minute. So those are the three basic things that I'd like you to be familiar with: FiO2, PEEP, and the respiratory rate. Okay, now, some of you might get anxious and say, sir, aren't you gonna talk about, let me just admit, some of your friends, I understand you guys, your internet are fluctuating. I'm so sorry for that. I just hope I can give you internet signals too, because they're sending me messages, sir, please wait for us. Our internet is fluctuating. I just wish I could also give you internet signal. Okay, anyway. So some of you might be asking, sir, will you not be talking about the mode of ventilation? My friends told me to study about it. Okay, in a nutshell, the basic things that you should know, you have your volume controlled mode and the pressure controlled mode. So what's the difference? Your volume controlled mode involves the delivery of preset volume of air. When you say preset volume of air, the ventilator will be programmed to deliver the normal amount of air that a person takes in to the lungs with each breath. And we call that tidal volume. Now remember, the tidal volume is usually computed based on the weight of the patient or the size of the patient. So the normal tidal volume could be 400 to 800 ml. That's the amount of air that goes into the lungs with each breath, okay? Now your volume controlled mode delivers that, okay? Now this mode of ventilation is indicated for patients with acute lung injury or ARDS, okay? Now, how about pressure controlled mode? Now, this involves the delivery of preset pressure to the patient. This is indicated for neonates, okay, who needs preset amount of pressure to keep their alveoli, okay, functioning properly, especially if they have immature lungs, okay? Okay, sorry for that, guys. I have to admit them back. Okay, so there's also a term that says assist control mode, okay? Assist control mode is a form of volume controlled mode, okay? So in the assist control mode, the patient will have a set respiratory rate. Therefore, for example, if the patient is not breathing within 5 seconds, okay, of being connected into the ventilator, it's the ventilator who will deliver a preset respiratory rate. Now, if the patient, on the other hand, still breathing, okay, so your ventilator would be in assist control. So it will just be on a standby such that when the patient will cease to breathe normally, then it provides assistance. That's why it's called assist control mode, okay? Okay. Now, this is one thing I'd like to highlight. Ventilator alarms. There are 2 alarms that you have to be familiar, the high pressure alarm and the low pressure alarm. like this. Why would pressure increase inside the system? It could be due to accumulation of secretions, accumulation of mucus. So it could also be due to coughing of the patient, or in a nutshell, there's obstruction of the endotracheal tube. So the priority would be to suction the patient's airway. Okay. Now, when the low pressure alarms, the one that sounds, it could be due to disconnection of the tubings or extubation. So in essence, you just have to reconnect or reintubate as necessary. So if you are given a question that says, the high pressure suddenly alarms, what should be the priority of the nurse? Suction the endotracheal tube. Or the low pressure alarm sounds, what should be the priority of the nurse? Reconnect or check for disconnection or check for extubation or reintubate as necessary. All of those interventions are appropriate. Remember these two concepts, colleagues. Okay, so once again, whatever we learned will be useless if we don't know how to use it. Okay, so let's try to answer sample questions. Here we go. While providing nursing care to a client on a ventilator, here we go, the high pressure alarm sounds. Which of the following interventions is the priority of the nurse? What did we say? The high pressure results from obstruction, accumulation of secretions. Therefore, what do we do? Give me an answer. Okay, so active. The chat box is so active. The chat box, 3. Everybody who gave answer number 3 will pass the NCLEX. We'll shut down at 60. 60 items. Okay. Excellent. Okay. Okay. Excellent. Okay. The answer is actually suction the client's airway. We don't increase the FiO2 to 100%. It's only up to 50% because increasing it to 100% will lead to the development of retinopathy, damage the small blood vessels of the eyes. Okay. Excellent. Okay, so always ask what if. What if I will be asked about ventilators? What if I will be asked about complications of ARDS? Remember, PICC. So your pulmonary fibrosis results, which means there's going to be damage into the lung tissues that would make it, that would restrict expansion, so breathing would be difficulty, infections, clots of blood, and of course pneumothorax or the collapse of the lungs. Okay, so ARDS survivors may develop depression. So in other words, if these people eventually survive because of the stress brought about by the breathing difficulty, eventually they develop depression. So you have to keep watch of them. Eventually, depressed patients become suicidal. Okay, so always remember again, the test taking key, don't forget the basics. Okay, we begin, and this is very basic. Some of you might be forgetting to study this concept, but I'm highlighting it now because I know if I'm not going to talk about it, some people would say, well, I forgot to read about it. Okay, so in the Philippines, going back to basics means during this time of pandemic, when we don't have adequate transportation, we go back to riding the carabaos. That's the basic. Oh, this is also one good thing. Okay, this is how we do our drive-through at McDonald's. Okay, because we are not yet allowed to have public transportation in the Philippines. So this is how we do our drive-through in McDonald's. Okay, I'm so conscious about pronouncing that properly because my students in America used to tell me, Ray, it's not McDonald's, it's McDonald's. Okay, so we say McDonald's. Okay, you are in America, you have to sound like an American. McDonald's. In the Philippines, say McDo. Okay. Okay, and of course, going back to the basics means converting the motorcycle into an ambulance only in the Philippines. Okay, but that's how creative we are as a people, right? Okay, so this is the basic thing that I'm trying to talk about. You have to study about informed consent. Not just the elements, not just the principles, but how you apply the concept. How you apply the concept. We begin. Okay, so remember that your informed consent requires full understanding of the procedure. Now, some of those friends of yours could be asking you, Is it proper to discuss the cost of a procedure when obtaining the informed consent? Lawyers agree that yes, it has to be part of the discussion. Why? When you're talking of informed consent, you have to consider three things. You have to consider discussing the benefits, the risks, and the alternatives, okay? Why? Because you need to protect the client. You need to protect the nurse, the surgeon, and the hospital. So the patient has to know how much out-of-pocket contribution they're going to shell out for the procedure. So you have to cover the cost, okay? Now, this is an important issue. Emancipated minors. Can they sign the consent form? Yes. And who are emancipated minors? Married minors, okay? Below 18 but married, they can sign the consent. Those who are in military service, those who are living away from home and self-supporting, those who had a child. Having a child simply means that if the patient is still pregnant, the patient is already considered as having a child. So they can already sign their consent for their cesarean delivery if they need to, okay? Okay. Now, pay particular attention to this. Any minor emancipated by law can sign their consent, okay? So before obtaining the patient's signature, the nursing staff and other professionals shall take reasonable steps to ensure that the benefits, risks, and alternatives of any procedure to be performed on the patient has been explained by the physician to the patient representative, or the surrogate, or the guardian, or if the parents are divorced, somebody who has a legal custody for the child. Okay, so let's try answering a sample question. A preterm infant in the neonatal intensive care unit with congenital cardiac anomaly was found to be in cardiorespiratory distress. A series of invasive and surgical tests and treatments were necessary, but the parents are not around. Here is the twist to the story. The parents are not around to provide the consent. The infant's aunt, who acts as the caregiver, is the one around. Which of the following interventions is most appropriate? Now, if you are in this situation, what are you going to do? Are you going to defer the surgery until a consent can be obtained, obtain consent from the aunt, ask the physician to exercise their option to perform the surgery due to the nature of the situation, or exhaust all means to obtain consent from the parents? Now, take note, you have a preterm infant. The infant is in a cardiorespiratory distress. This is an emergency condition, and you have the aunt who acts as a caregiver. So obtain consent from the aunt. That is the best option. Now, let's talk about the application of this concept. What if you are being asked about informed consent for teenagers who are below 18 who would want to have tattoo or body piercing? Okay, now remember, they can do tattoo or body piercing without parental consent when they turn 18. But if they are less than 18, they have to be accompanied by a guardian or by one of the parents, and they have to have the parental consent form for all types of piercing, okay? And even if they have the parental consent form, piercing at some body parts like the genitals are not allowed. That is not legal, okay? Okay. So pay particular attention once again to the basic concepts like informed consent. Okay. So let's move on. Always ask what if. Always ask what if. So let's summarize that informed consent thing. If you have a minor below 18, okay, who wants to do body piercing, okay, they have to be accompanied by a guardian, one parent, or they have to be the parental, they have to have the parental consent form. Okay, if you have an emancipated minor who is pregnant, who should sign for the consent? The emancipated minor. But if in the absence of the parents, if you have a pediatric patient who could sign on behalf of the parents, now it's gonna be the guardian. I have a question, okay? I have a question, and I'd like you to put your answer into the chat box, okay? And somebody who will actually put the answer into the chat box will receive this correctly, okay? Sir George, you have to take note, who will answer this correctly. Oh, it's gonna be easy, okay? Are you ready, guys? Okay, the question is, what if, okay, what if you have a male child, okay, whose circumcision was facilitated by the parental consent? The question, okay, here's the question. Is the parental consent valid or not? Okay, put yes if it is valid, put no if it's not valid. Go! Okay, who's the first one to answer yes? Is it valid? Who's the first one to answer? George, you have to help me out. Okay, the first one to answer yes, I think is... Okay, Revelo Arnold. Okay, congratulations, Revelo Arnold. This is yours. Okay, okay. I would like to explain that. Several years ago, the position of the American Academy of Pediatrics is that, okay, informed proxy parental consent would only be allowed for procedures that are considered essential for health. Several years back, circumcision is considered a matter of preference. Some, they do it for cultural reasons. That's why there is mujer circumcision. However, with the increasing evidence of increased HIV transmission in non-circumcised males, in which around 50 to 60% more risk if they are uncircumcised, then it has been considered as an essential procedure that could potentially protect the child and help promote health. Hence, it is now considered as valid. Okay? So the parents can now sign for the consent of a child for circumcision. Okay, excellent. Okay, so we're gonna send that thing to our winner. Okay, I think it's Arnold. Congratulations. Okay, so let's talk about pressure injury. Okay, now your pressure injury used to be called bed sores. During my generation, it's called pressure sores. Okay, now it's called pressure injury. Okay, now it's very important for us nurses that we document the presence of a patient's pressure injury upon admission. It has to be done within the first 24 hours. Actually, okay, the expectation is you have to document it within the first 6 hours. Why? Because, okay, if you don't document that the patient already had it upon admission and eventually it gets discovered, that would be labeled as hospital-acquired pressure injury. And, okay, that would have some implications on the insurance claim of the patient. Okay, so let's move on. So pressure injuries are injuries to the skin and underlying tissues and who are at risk to develop pressure injury. You have patients who are wheelchair bound, aging adults, neurological conditions like Alzheimer's, okay? Patients who are exposed too long to pressure, and those with excretion problems, those with bowel and bladder incontinence, those with diabetes and deficient nutrition. I'd like to highlight one thing: the wheelchair bound and the aging adult. Now take note, will the use of your donut ring help a patient who's wheelchair bound prevent the development of pressure injury in the sacral area? No, the donut ring could actually exert pressure on the surrounding tissues, and that's not good for the patient. So that's not indicated, okay? So what I'd like to highlight, what should you study for pressure injury would be the stages, okay? Sir, what specific aspect? How it looks, because you will anticipate that sometimes you'll be given a picture, then you'll be asked to label it, whether it's stage 1, 2, 3, or 4. Or sometimes you could be given 2 pictures, okay? showing the progression, whether the pressure injury progressed from stage 3 to stage 4, or the pressure injury improved from stage 4, it has now become stage 3. Then how do you document the change in the wound? Okay, so you have to be ready for those types of questions when you are studying pressure injury. Okay, so look at stage 1. Usually in stage 1, the skin is intact. Okay, and people would say, how do I manage it, sir? You don't have to manage it. There's nothing to manage. Okay, the skin is intact. All you have to do is to document it and pay particular attention on monitoring it, because there's a greater possibility that it could potentially progress to a higher stage. So there's no open wound, there's just a reddened skin. In dark skinned patients, it will have a different color. There's no blanching. When you press on the reddened area, it doesn't blanch and the skin would be warmer. So how will you do it? Manage with frequent change in position every 1 to 2 hours. You may ask the patient to use pillow support, or we could actually use mild soap and water, and take note, use foam and moisturizer. The question is it all right to use moisturizer? Yes, because a skin that's just so dry, okay, could be easily cracked. And when the skin is cracked, that's the first line of defense, infection could sit in, okay? So how do we differentiate now? Stage 1, the epidermis becomes red from stage 2. Now, take note, in stage 2, you have a fluid-filled blister. Okay, so when you have a blister that's formed, that's already stage 2. Okay, in stage 2, you have an open wound. The ulcer now is painful and tender and blister with clear fluid. So there's gonna be a crater for stage 2. The epidermis and the dermis could be affected. When a patient has a stage 2 pressure sore, once again, it's usually cleaned with saline solution. Now, hydrogen peroxide is usually not indicated as it harms the skin, okay? So cover it with a dressing, gel or foam. You can use petroleum jelly to keep it moist, and then the patient could have antibiotic ointments. Now, pay particular attention to the fact that you are supposed to be using hydrocolloid dressing, okay? Hydrocolloid dressing, okay? Then stage 3, take note, the sore extend under the skin. So you have the epidermis, the dermis, and then you have the fats being exposed now, fat exposure. Now, fistula could develop. Fistula could sometimes be described as tunneling. What's tunneling? The pus here could actually bore, okay? It could actually tunnel through, okay, underneath the skin. So what results if that happens? What results is that in stage 3 pressure sore, what you see may not tell you the whole picture. There's more underneath because of the tunneling, okay? There's a fistula formation. So a hole is usually born out of the underlying tissues, okay? So in stage 3 pressure injury, no massage is allowed, okay? The priority should be to debride and dress, then provide proper nutrition that should be high in protein, hydrate the patient, and take note, pay particular attention to keep the head of the bed low to prevent shearing force, especially in the elderly, where the shearing force, I mean the contact of the skin with the linen could actually damage the skin and worsen the condition, okay? In stage 4, take note, you have a deep injury. It affects this time the muscles and would expose now the bones. Okay, look, no wound, stage 1, blister, stage 2, fat exposure, stage 3, bone exposure, stage 4. Okay, remember that. And then, once again, the priority is just to debride and dress. Okay, now, let's have the what if again. What if you are shown a picture like this and you are asked to label it? See? This is actually what's a common difficulty. What we have here are drawings. And the stage 3 in the drawing doesn't look like the actual thing. So, if you are to familiarize yourselves with pressure injury, browse through several pictures because no 2 stage 3 pressure injuries would look the same. Okay? Your hallmark should be the fat exposure. Okay, So this is stage 3. What if you have this picture? And then the question is asking you, how will you label this in terms of staging? So you'll have to type stage 3. Okay. Now what about if you are shown this? Oh, that's deeper. Okay. So you have the presence of a bone. Okay. It affects the muscles and the bones. Okay. Okay. So this is deeper. It has affected the muscles and has shown this whitish thing could be a bone. Okay. So this is actually your stage 4. Okay. This is actually for educational purposes. Okay. So let's try answering a sample question. It's easy if you are just being shown pictures. But what if the question will not ask you or will not show you pictures? You have to be ready. You always have to know what if, okay? Look at this class. This is what I'm trying to tell everyone, okay? The nurse is assessing a client's pressure injury. Upon examination of the wound, the nurse notes that the bone, muscles, and cartilage are no longer exposed as were previously noted some weeks back. A layer of fat is, however, visible. That should give you the clue. So it used to be that the bones, muscles, and cartilage are exposed, and it's no longer exposed now. So this used to be stage 4. But at this point, a layer of fat is visible. So layer of fat is stage 3. So is that a sign of improvement? Yes, from stage 4, it's now stage 3. Now, the question is, which documentation entry best describes the correct way of documenting the improvement in the patient's pressure injury? This is what is difficult, colleagues. This is what I'm trying to tell you. You would be so adept and precise in classifying by picture which one stage 1, stage 2, stage 3, stage 4. But when you are faced with a situational scenarification of an event like this, then it becomes a little more confusing. Especially that it's integrated with the concept of documentation. How do you document wound improvement? First, do not label. Always describe as to appearance, color, size, location. Okay? Do not simply say it has improved from stage 4 to stage 3. No. And avoid being subjective. You just have to present data objectively. Okay, so let's analyze the options. The wound has improved from stage 4 to stage 3. This is a too general statement. You are not. Okay. Okay, sorry for the interruption. Okay, when technology fails, sorry for that, colleagues. Okay, this is just too general. Look at number 2. Reddish skin surrounds the ulcer on the sacral area, which is approximately 1.5 centimeter in diameter. You're describing the location. You're describing the size. Previous exposure of bone, cartilage, or muscles no longer noted. You are describing now an improvement and some fat cells visible. Now, question. Could this be considered? Yes. But look, colleagues, look. Even if you are already convinced that option 2 is correct, still read through the other options. 3, the pressure injury has gone from stage 4 to stage 3 in a week's time. Great progress in the healing noted. This is subjective. Okay, this is very subjective. You're praising yourself. Number 4, wound healing is taking place as predicted due to the great care of the nurse. Once again, that is being subjective. So the best answer, therefore, is excellent. Okay, number 2. Okay. Great. Okay.
Number 2.
Are supposed to be descriptive. Describe what happened. Describe the progress. Do not label. This is simple. I'd like to integrate class. What about if you are being asked to document the behavior of a patient with psychosis or bipolar disorder? Okay, you don't place on the chart, the patient is hallucinating. Why? What would look like hallucinating for you may not necessarily look like hallucinating for another nurse. So the key is to describe the patient's behavior. Say, the patient is trying to attach his ear to a side of the wall as if hearing something. That is descriptive. Okay? Okay. You don't label the behavior. You have to describe describe it. To describe it means you have to be specific. Okay, so document when a wound changes category, and to do that, you need to describe the wound. Do not document other skin injury with other etiology other than pressure injury. So if you're being asked to just document pressure injury, even if there are rashes that are caused by other factors within the area, just document the pressure injury, okay? So let's summarize what we just studied. Stage 1, non-blanching, reddened intact skin. Stage 2, partial thickness, loss of skin without slough. You have shallow open ulcer, blister. Stage 3, deep ulcer with white-yellow scar. Take note, no bone, muscle, tendon exposure, okay, but there's fat exposure. Stage 4, when you have bone exposure with black or brown scar. Now, deep tissue injury is considered when you have a maroon or purple intact skin with blood-filled blister. So there's no opening, but there's blood-filled blister, that's DTI. Now there are certain sores that are considered unstageable when there's a mixture in terms of the color of the area, like there's a mixture of gray, green, brown, black scar. There's full tissue loss with base of the ulcer covered with slough. So which means you cannot classify whether this is stage 1, stage 2, or stage 3. You just say unstageable, okay? Now, pressure injury may develop in bony areas like back of the head, back, shoulder, elbow, buttocks, hips, heels, and ankles. So back of the head, shoulder, elbow, buttocks, hips, ankles, okay? From head to toe. That if that could be turned into a select all that apply concept, it's easy. Just imagine the picture. Okay. Now, what if I ask you, which one do you think, will develop pressure injury? Which one do you think will develop pressure injury? Is it the turtle or the rabbit? Okay. I'd like to know your thoughts, guys. Which one would develop pressure injury? Is it the turtle or the rabbit? Most of them answered the rabbit. Some of them answered the turtle. Actually, okay. I'm going to give away my hat to someone who would get this question correctly. Actually, the turtle and the rabbit, okay, are talking to each other, and the rabbit, acknowledging that he moves faster, wanted to get away with something from the turtle. So the rabbit challenged the turtle. Who do you think wins in the challenge, okay? Is it the rabbit or the turtle? And here's the challenge. The challenge is, who between the two will arrive in their home first? Go, say the rabbit or the turtle. Okay, some of them are saying the rabbit, some of them are saying the turtle. Okay, here's the result. Sinong nakauwi agad? It's the turtle. Even if the rabbit moves faster, okay, we'll let you know who won my cap in a while. Okay, George will help me out. Check it there. Okay, George will help me out on who won. Okay.
Dati na po siyang nasa bahay.
Yeah. Okay, that's the challenge. Okay. Pero may nagsagot pa rin na the rabbit. Okay. So always remember to know your strengths. Okay. So just print it there, George, and we're gonna inform them at the end of our session. Okay. Thank you for participating in our game. 2 down, still have 1 more to go. Okay, now how do we prevent pressure injury? Okay, this is what is important. Avoid slipping or sliding on bed. This is shearing force. That's why you have to keep the head of the bed low. Don't keep it high to prevent shearing force. Use powder on the sheets. This is allowed, okay? And then instruct the client to lose weight, okay? Avoiding massage on the area near the injury and avoiding the use of donut shape or ring shape cushions. This could exert pressure on the other areas surrounding the injury, okay? Now, this is very, very important, okay? What are the things that we need to observe, okay, and report to the healthcare provider when a patient has pressure injury, okay? Observe for foul odor, the presence of pus, redness or tenderness, swollen skin, and fever. And you need to refer this to the healthcare provider. Okay, Now, a lot of people are asking me about anorexia nervosa and how it differs from bulimia nervosa. A lot of them are saying, my students in the graduate school are saying, we're confused, sir, because the criteria are almost the same. What's the difference? Okay, very, 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 very good and valid question. Okay? Let me differentiate them. Highlight two important things that differentiates anorexia from bulimia. First, in anorexia, there's fear of gaining weight. Okay? So one of the criteria to come up with a diagnosis of anorexia, there should be considerable weight loss. Usually more than 15 to 20% of the body weight. Okay? In bulimia, there is distortion. Okay? There is actually a distortion in body image, but there's no loss of weight. So the difference is actually on the weight loss criteria. Now I have a question. What if in the question, I'm having difficulty on the test to classify whether it's anorexia or bulimia? How will I deal with it? Experts agree that when the patient exhibits manifestations of both anorexia and bulimia, listen up, treat the patient as a case of anorexia nervosa. Now, anorexia originally was believed to be psychological in nature. This is the adolescent's way of rebelling against their parents for controlling their lives. They want to show their parents that they can control themselves, and so they control the food that they eat. Okay, that's old school. It has been found that in patients, okay, in patients, what are donut shaped? Donut shaped, those are donut shaped pillows, okay, which are not supposed to be used for patients with pressure injury, okay? So therefore, in patients with anorexia, okay, it's very important to identify whether they have a history in the family, because recent evidence suggests that anorexia nervosa has genetic basis, okay? So several researchers have found evidence to suggest that there is an inherited predisposition to anorexia nervosa, and that's more than 50%. Now, what are the manifestations of anorexia nervosa? I'd like you to focus here, colleagues. Pay particular attention to this, okay? Somebody said, sir, persistence is the key. Yes, okay? Eventually you'll succeed if you persist. Okay, so manifestations of anorexia. You have the code anorexia, beginning with A, arrhythmia. The arrhythmia is due to hypokalemia. Okay, you would ask me, is there vomiting in a patient with anorexia? Yes. Okay, yes, there is vomiting. And is the vomiting induced? Yes. Okay, so how are we going to differentiate, okay, the binging in a patient with anorexia plus the binging in a patient with bulimia? Now take note. There is a binging, okay, as well as vomiting, purging, binging and purging in a patient with bulimia, but there's no weight loss. In anorexia, the induced vomiting or the purging leads to weight loss. And because there is vomiting, that leads to hypokalemia that triggers potentially arrhythmia, okay? Now, amenorrhea is no longer considered a criteria for anorexia. Next, no other organic factor accounts for the weight loss. So the patient's not suffering from any medical condition. Obviously thin but feels fat. The anorexic patient, when they look at themselves in front of the mirror, they see themselves as still fat, but they, in reality, they're already thin. Refusal to maintain ideal body weight. This is one of the most significant criteria. They have epigastric discomforts like vomiting. I call them the X symptoms. They hide food all over the house, okay? They collect recipes. They love to prepare foods. They love to cook foods, okay? They love to invite people for dinner, but they don't eat with these people. They just rearrange the food on their plates. And then they have intense fear of gaining weight, and they always think about food. So the priority for the anorexic patient is to monitor their weight. and to keep them in a public place after meals so they don't induce vomiting. What does that mean? We don't allow them to use the restroom, or we don't allow them to go to the bedroom right away after meals, because in that case, they have a privacy that potentially allow them to induce vomiting to themselves. So what is important here to note, class, take note, is that if you have the anorexic patient, the priority in terms of treatment would be cognitive behavioral therapy. Okay? So we assist the patient, okay, to identify factors. Like, for example, how would you know that you have an anorexic patient? How does it develop? Usually the parents of anorexic are perfectionists. Okay, and the teenage child, the anorexic teenage child, would have body dissatisfaction. They have strict dieting, very low self-esteem, difficulty expressing their feelings, plus history of physical or sexual abuse in the family. Bring all these factors together, plus genetic, okay, predisposition, and you have an anorexic. And an anorexic would usually lie about food eaten, socially withdrawn, with dry yellowish skin, bluish tinge on the fingers. Sometimes they have the Russell sign or callus formation here from inducing vomiting. They have intolerance to cold because they have less fats in their body, and they usually would have arrhythmias, okay? So what's the expected outcome for a client with anorexia nervosa? Is to have sufficient weight gain. This is the long-term outcome. This is the long-term outcome. The short-term outcome would be for the patient to avoid inducing vomiting by staying in a public place, okay, after meals, okay? So referral to a behavioral program should be made if the patient is having less than 75% of the ideal body weight for adults and a BMI of less than 16.5% for children. Listen, colleagues, I'd like to focus on BMI. What is the normal BMI? It's 18.5 to 24.9. Okay, when the BMI, listen up, when the BMI goes up to 25 to 29.9, then the patient is already overweight. If it goes 30 or more, then the patient is considered obese. So once again, the normal BMI, 18.5 to 24.9. Okay, what is the formula for your BMI? Always remember this, kilograms divided by height in meters squared. That's as simple as that. Weight in kilograms divided by height in meters squared, okay? Don't forget, okay? So BMI, weight in kilograms divided by height in meters squared, okay? So here we go. Anorexia nervosa can lead to the following development of which of the, following, sorry. The question is asking about complications. Will we have hyperkalemia? What we usually have is hypokalemia due to the vomiting. So this is an X. Growth of a layer of fine hair all over the body, yes. They will have lanugo. Brittle hair and nails, usually yes, because of the malnutrition. Lack of appetite, actually, anorexia is a misnomer because anorexic patients, they don't lack appetite. They have appetites, but they suppress their appetite. So this is not an accurate description of the patient. So we put an X, and then thinning of bones, okay, could potentially occur in patients with anorexia. Okay. So which of the following is an appropriate short-term goal of care for a client with anorexia? This is a keyword, short-term, okay? Normal body weight is a long-term goal of care. What did I tell you a while back? If you talk about short-term goal of care, we're talking about instructing the client to remain in a public place after meals to prevent them from inducing vomiting. Okay, so to sustain the weight gain program, the patient needs 3,500 kilocalories over maintenance requirements for every pound gained. Okay, so when you are monitoring the weight of the anorexic patient, you have to monitor it 3 times a week. The weight gain should be 0.75 pounds over the previous body weight. So the total weekly goal of 1 to 2 pounds a week is realistic. Okay. So refeeding syndrome is a potentially life-threatening condition that can occur in clients with anorexia nervosa. What is refeeding syndrome? This occurs when patients who have been malnourished and starving for the longest period of time, all of a sudden is given food. Okay, so what happens? There's gonna be a shift in terms of the fluids and then electrolytes. So eventually, when refeeding syndrome occurs, there's an imbalance in the fluids and electrolyte levels of the patient, and this could be potentially fatal, okay? So this is brought about by metabolic and hormonal changes brought about by malnutrition, okay, and starvation. Okay, once again, I'd like to share with you this nice note I received from a student. Reynold, sorry. This changed my life tremendously. It opened doors for me. It gave me so many opportunities. Thanks to Gapus. Thanks to Dr. Ray for his sacrifices. I have so much respect for your genuine love, kindness, and boundless generosity. May you continue to be a blessing to many nurses. I'm a proud Gapus baby here. Mabuhay, Gapus. Okay, that's Reynold, okay, who was my student, okay, way back 2004. And he shared this once again on my wall on Facebook, okay? And of course, we have, okay, somebody here, okay? From the New Mexico Board of Nursing, okay, Pooja, okay, who passed the NCLEX through our program, okay, and another who says, thank you for your support. So I asked her, what concepts did you encounter that we did not discuss? Actually, there weren't any. Everything that came out were discussed by you in our class, and the strategy to tackle the questions. Thank you very much for that feedback. Great, thanks for the great feedback. Okay, once again, our nurses from India and Nepal, okay, joining us for dinner. Okay, now let's talk about your benign prostatic hypertrophy. Okay, now this is common among males, of course. You don't have prostate for females, okay, who are usually age 40 and above. Specifically, those who are of African descent are at a higher risk, okay? So in BPH, okay, let me just admit one of our friends. In BPH, okay, a common observation is that there's proliferation of muscles and cells in the prostate. And a lot of people are saying if it doesn't bother them, they usually don't get consultation. But there's a great chance that this could progress, then eventually may alter the patient's urinary functioning. So what are the common early signs of BPH? Frequency, frequent urination, urgency, they always feel the need to void, decreased size and force of urinary stream, dribbling at the end of urination, frequent urination at night, and inability to empty the bladder completely, okay? Now, focus on this group of manifestations. But what if the test will not ask you about labels like this? What if the test will ask you about how patients will describe the symptoms? Okay, like this. See, which of the following statements, if made by a male patient, needs further evaluation to ascertain benign prostatic hypertrophy? Look, my urine is straw-colored, sorry. So you have here now a patient statement. Okay, so sometimes we are so focused on memorizing medical terms and labels that we forget how laymen, people from different walks of life will describe the symptom. Straw-colored urine, okay, is not indicative of BPH. So we put an X, okay? Sometimes that's normal. I have difficulty initiating urination. Okay, this could be indicative of BPH, okay? I oftentimes wake up at night needing to go to the bathroom to urinate. That's nocturia, yes, okay? I'm having cloudy urine. A cloudy urine could indicate urinary tract infection. That's not a sign. I'm having some reddish color in my urine. Now, this is where a lot of nurses are having difficulty. I'd like to highlight these things, class. You have to know that hematuria is a sign of BPH. However, it is a late manifestation. So if the question is asking you, which of the following are early signs of BPH, you don't include hematuria. But if the question is asking you, which of the following needs further evaluation, in general, it's asking you the manifestations of BPH, then we will have to include hematuria, okay? Okay. So less common early signs of BPH includes inability to void, UTI, and hematuria. These are less common. Once again, less common, and they may occur late, okay? Now, the initial test for BPH includes your digital rectal exam, urine test, and your prostate-specific antigen blood test. So for mild to moderate cases of BPH, medication is the most common treatment, okay? And alpha blockers to relax the muscles of the bladder are given, like your tamsulosin or Flomax, or silodosin or Rapaflo. And then you have your alpha reductase inhibitors that shrinks the prostate, like finasteride. Now, it used to be that an herbal remedy, Palmetto, has been identified as having finasteride-like effect of shrinking the prostate. However, recent evidence suggests that there's no direct link between Palmetto and the shrinking of the prostate. So it's no longer being advocated. Now, pay particular attention to the fact that when you have a female nurse who is administering finasteride or Proscar, okay, always remember that finasteride could be absorbed in the skin, okay? And this could potentially lead to birth defects. So therefore, if we have a female patient who accidentally touch the finasteride with their hands, okay, just instruct her to wash the skin with soap and water. Okay, now, question. You have here the drug Tadalafil or Cialis. I have something to highlight. Tadalafil or Cialis is actually indicated for patients with erectile dysfunction. How come it's now given to patients with BPH? Now, the purpose of your Tadalafil or Cialis in patients with BPH would be, it is actually to relax the bladder musculature as well as the prostate. So in essence, it decreases, okay, the difficulty in urination. So it decreases the difficulty in urination. Okay, so what are the things, discharge instruction, take note of this class, what are the things or the discharge instructions that you will have to tell your patients with BPH so that they can control the symptoms? Limit fluids for 1 to 2 hours before bedtime. Okay, limit caffeine and alcohol because it would actually caffeine would actually stimulate urination. Okay, limit decongestants and antihistamines. Urinate regularly at scheduled intervals. This is to train the bladder. Practice double voiding. So instruct the client to void and then after a while void again to completely empty the bladder, and then keep the patient warm because cold would usually stimulate micturition. Okay, so the risk factors to BPH, remember loads, lifestyle and family history, obesity, take note, aging, common one, diabetes and heart disease, and specific medications like beta blockers. Okay, now, what if? Let's use the what if mentality again. What if on the test you will be asked symptoms that are common to both prostatitis and BPH? Now, take note, the risk factors, both could be developed secondary to urinary tract infection. Okay, BPH is a risk factor to prostatitis, and prostatitis is a risk factor to BPH. Okay, here, okay, prostatitis could be secondary to rectal intercourse, BPH could be secondary to urethral stricture, and prostatitis could actually lead to related to dehydration and pelvic trauma, and BPH related to kidney stones, cancer of the prostate or bladder, aging, family history, DM, and obesity. Now, how do you differentiate the symptoms? That's what I'd like you to focus on. Remember, high fever occurs in acute bacterial prostatitis and not in BPH. So what symptom differentiates the two? It's high fever, which occurs in bacterial prostatitis. For the others, like frequency, urgency, nocturia, it could occur in both. Okay? Now, let's move on to another condition that's common to teenagers and young adults, from high school students age 15 and young adults age 35. So this is common among those who are between 15 to 35 years of age. So let's talk about testicular cancer. A common risk factor to testicular cancer could be undescended testes. And if you talk about undescended testes, listen, colleagues, okay? It could potentially develop to testicular cancer. So that's number one in our list. Remember, UFAR, undescended testes, family history, age and conditions such as Klinefelter syndrome. Let me talk about Klinefelter syndrome. So Klinefelter syndrome is a chromosomal abnormality in which the normal XY combination in chromosomes becomes XXY. So you have an extra X chromosome such that the secondary sex characteristics of the patient would be underdeveloped. So how would a patient with Klinefelter syndrome look like? They are tall, okay, However, they have underdeveloped secondary sex characteristics, including undescended testes. Okay, and take note, testicular cancer could also be related to one's race. Okay, usually it's common among whites. Okay. Okay, now what are the manifestations? You have the cold paddle, pain in the testicle, scrotum, or back, a sudden collection of fluid in the scrotum or hydrocele. Okay, you have to assess that. You can use a flashlight to do so. Dull ache in the abdomen or scrotum. Okay, discomfort in the testicle or scrotum, lump or enlargement in either testicle, and enlargement or tenderness of the breast. Okay, so gynecomastia, which is secondary to hormonal imbalance brought about by a patient with testicular cancer. Okay, now here we go. In the past, if you're reading a little older literatures, you would notice that spongy testis is considered as a sign of testicular cancer. However, if we're going to read recent literatures, what you will find would be that the normal testes are firm with slight spongy feel. Now, ladies, tell me, the normal testes are equal or unequal? Come on, enter the answer in the chat box. The normal testes are equal or unequal? Go. Okay. I suppose most of you here are married. Okay. The left testicle is usually lower than the right. So they are unequal. Excellent. So it's not a cause for alarm if the testicles are unequal. Okay. So testicular self-exam is usually done either during or after a warm bath so that the testicles will sag. Okay. And this is how it's done. So instruct the client to stand up. Okay. Raise one leg like this. And then using the thumb and the other fingers, palpate from one area and then proceed to the next. Okay. Okay, now, what about if the question on the test would integrate, wow, more than 5 conditions? Sir, is that possible? It's not an impossibility. It's better to be prepared than to lack preparations. Okay? It's better to be over-prepared. Let me give you an example. Look at this class. This is the negative focus question. Sir, what do you mean by negative focus? Yeah. Sometimes we are too busy focusing on the drug of choice, the first line of treatment, the best treatment option, the gold standard of treatment or therapy. But sometimes we forget to study which treatment could be inappropriate. And sometimes questions on the NCLEX would actually focus on these things. You will actually be taken by surprise when you see one. Okay, look. Schizophrenic patient, okay, with levodopa. The question is asking which condition is treated inappropriately. First, how do you deal with this? Go back to the cause. Schizophrenia is due to increased dopamine. What is the effect of levodopa? Levodopa increases dopamine. Therefore, if you administer levodopa to a schizophrenic patient, you worsen the condition. So it will increase delusions, hallucinations, confusion. So is this inappropriate treatment? Yes, so we put a check. Now, but some people would usually be asking, sir, why are my patients who are taking antipsychotics are being given levodopa? Hey, that's where the difference lies. If a schizophrenic patient is taking antipsychotic, the adverse effect of antipsychotics will be decreased dopamine. That's the reason why the patient will develop pseudo-Parkinsonism. That's the reason why levodopa or an anti-Parkinsonian agent is given. So therefore, let's clarify. You can give levodopa to a schizophrenic patient if the patient is taking an antipsychotic. But you cannot give levodopa if the patient is not taking antipsychotic because levodopa will worsen the symptoms of schizophrenia. Excellent. Okay. Second, thalassemia. So thalassemia is a genetically transmitted blood disorder. Okay. You have your thalassemia intermediate, thalassemia major. Okay. You have your alpha thalassemia and your beta thalassemia. Okay. What's the main problem here in thalassemia? In thalassemia, there's a transmission, okay, of the gene that causes the condition in autosomal recessive pattern. Okay, so what happens? Okay, there's an abnormality in the alpha and beta chain that eventually leads to RBC destruction. So what is the main problem in thalassemia? Destruction of red blood cells. Will that lead, sir, to anemia? Yes, very good. So a complication of thalassemia will be anemia. Excellent. So therefore, is it all right to give iron? No. Why? Let me explain. In thalassemia, because of the increased destruction of RBC, okay, the iron and globin component of the red blood cell separates, such that the iron component of the destroyed red blood cells are deposited into the tissues. You now have a condition known as hemosiderosis, an iron excess or iron overload. That's why the treatment for thalassemia is not iron. You have to give the drug that is given to promote excretion of iron, like deferoxamine or desferosirox, okay? Or you have to give blood transfusion, but not iron, okay? Because iron will worsen iron overload in thalassemia. Question, is that inappropriate? Yes. If you give iron to a patient with thalassemia, that's inappropriate. So we check because the question is asking for something inappropriate. Next, hyperkalemia. You have elevated potassium, more than 5.3 milliequivalent per liter. Spironolactone, potassium-sparing diuretic. Will it worsen hyperkalemia? Yes. So is this an inappropriate treatment? Yes. So we put a check. Atrial fibrillation, okay? The atria contracts at a rate of 400 to 600 beats per minute. So what medication will we instruct the patient to avoid? Medications that could potentially increase atrial contraction. And you have milrinone, adenosine, atropine sulfate, dobutamine. Therefore, is atropine sulfate contraindicated in clients with atrial fibrillation? Yes. Is that an inappropriate treatment? Yes. So we put a check. Okay, here we go. Here's cholecystitis and pancreatitis. Several years back, they said morphine causes spasm of the sphincter of Oddi in biliary conditions. That's why morphine causes more pain. However, evidence in recent literature suggests that it's not morphine that increases the spasm of the sphincter of Oddi, but it's codeine. Therefore, will codeine worsen the pain in cholecystitis? Yes. So is that inappropriate? Yes, it's inappropriate. Now, will morphine worsen the pain in pancreatitis? Recent evidence suggests no. There's no direct link. Therefore, is that inappropriate? It's not inappropriate, so we put an X. This is what is difficult on the NCLEX. When you have a question like this that covers 6 different conditions and 6 different treatments that are inappropriate. It's not even asking you about the drug of choice. It's asking you which drugs are contraindicated. And you have to be very, very careful. And that's the reason why I came up with this to summarize things that I'd like to highlight for you guys, because I want you to pass your NCLEX. I want you to turn your great American dreams to reality. And that's my mission. As I've been saying, coaching people to pass the test has always been my passion. Okay? And I would want to do my best to help you out at this point in time so that you'll reach your dream and goal. So always remember, if you've seen things as difficult, all things are difficult before they are easy. It becomes easy with a functional concept method. Okay? So, the Lucky Charm giveaway time. I'll just announce who won. George, who won the cup? Okay. Do I have the name now? Who won the cup? A while back? The blue cup? Okay. And the name is? Okay. Drum roll! Okay.
Merry Christmas.
The name is for the one lucky lady. Okay, the name is, okay, Mary Chris Sardane. Okay, okay, okay. And then somebody asked me, sir, can you show again the table for pressure injury? The table for pressure injury, you have a copy, right, colleagues? Yes, you just have to print your handouts, okay? You have a copy of the slides, of the pictures. I've given them to you so that you will be able to remember it, okay? So somebody's asking me to show it again. You have a copy, okay? You have a copy. You have a copy. Okay. So let me just welcome back some of our friends. Connect on, okay. Thank you, Sir Ray. Yes, I print mine. Hopefully get the chance to get that giveaway. Yay! Thank you so much, sir. I won. Congratulations, Merry Chris. Yes, we do have. Kala ko ako na. Okay, so we'll send you the gift through Grab. Okay, my way of sharing my collections with personal. Okay, for somebody to win this blue cup, you have to identify which position do I occupy in this picture? Is it 1 or 2? What position do I occupy in this picture? Is it 1 or 2? Okay, load it now on our chat box.
2.
1 or 2? A lot of them have 1, a lot of them have 2. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, time is up. And let's find out what position do I occupy. Is it 1 or 2? I know what you're thinking. You're judging it from the belly. Okay, do not judge a picture by the belly. Okay, okay, let's open. Okay. Okay, I'm occupying position number 2. Okay, so the first one to give that answer is actually the winner. But, okay, the winner of the blue cup. I'm going to give a bonus prize to the one who could give me the answer. Later on, I will announce when will you log the answer. Think about who is the person I'm with in this picture. Okay? I will ask you to log on the answer, not now, later on. Okay? Okay, this is actually the end of our session 4. Let's have a 90-second bladder break and a drinking break. And then after that, we're gonna proceed to, okay, session 5. So remember, here's, once again, Mentor Ray. Oh, that's my graduation pic in the US. Okay. A functional concept a day keeps your NCLEX RN fears away. So if you love this video, please don't forget to subscribe and hit the like and bell buttons, especially in our YouTube page, Gapus Mentors. Okay.